Good afternoon, everyone. My name is Dr. Eric Toring. I'm the Senior Vice President for the American College of Veterinary Preventive Medicine, and I want to welcome you to today's webinar. Our webinar is sponsored by the American College of Veterinary Preventive Medicine and its partner organizations, the National Association of Federal Veterinarians, the American Association of Food Safety and Public Health Veterinarians, the U.S. Animal Health Association, and the National Association of State Public Health Veterinarians. I would like to welcome our speaker today. Dr. Amy Stone is a native of Gainesville, Florida, and a two-time alumnus of the University of Florida. She obtained her veterinary degree in 1999 and her PhD in 2002. Her PhD focus was in pulmonary immunology, and her postdoctoral research after graduation involved investigation of a human periodontal vaccine at the University of Florida College of Dentistry. Since 2006, she has worked as the chief of the primary care and dentistry service at the College of Veterinary Medicine at the University of Florida. Dr. Stone has a passion for teaching and strives to help achieve competent as well as confident veterinarians that are able to practice on the first day of their careers. She believes that veterinarians have a critical role in One Health and in defending the safety of animals, humans, and their environment. Dr. Stone enjoys learning from and teaching veterinary students, along with finding new methods, techniques to provide them with opportunities for clinical learning. She helped to establish the Clinical Skills Laboratory and curriculum for students to develop and practice their technical skills. She has worked to expand the communication education in the preclinical years at the University of Florida College of Veterinary Medicine. And she's been a leader in growing the primary care and dentistry service, as well as the overall dentistry curriculum in the last 18 years to one of the largest in the nation. Dr. Stone is married to a small animal veterinarian, has a wonderful stepdaughter, and several animal family members, to include a dog, a lizard, and a bird. She enjoys biking, hiking, and traveling to new places. So welcome, Dr. Stone.
Thank you, Dr. Toring. It's my pleasure to talk to everybody today. We're going to talk about cats, and their vaccines, and making it the best that we can, worth our while, if you will, not wasting our shot. I got to be part of the vaccine task force back when the AAFP was the AAFP to write the guidelines for cats this time, and it was truly a pleasure. Cats often get forgotten about, I think. They can be challenging. So today we're going to talk about risk factors and sort of clarifying what those risk factors are. We have some new vaccine schedules. So we had some changes in 2020 that kind of got buried because of the whole COVID situation. And so we're going to talk about some minor changes that might make a big difference to practitioners. And feline leukemia is always one of those, do we give it, do we not, when, how often, all those kind of things. So we're going to hopefully clarify that a little bit for everyone. And then we're going to talk about there are some therapeutic options for some of our vaccines. So we're going to give that a little bit of a whirl as well. And then we'll talk about some adverse events, including fibrosarcoma, which is unfortunate, part of what we have to do, but we should definitely talk about it. And then we're going to talk about some vaccine storage issues, because it's one of the things I find in going around to practices is that vaccine storage becomes quite a bit of a problem when people don't actually know about it. It's something we're not necessarily taught in vet school. And then vaccine population issues. As general practitioners, small animal practitioners, we need to be part of that story, and we need to be part of that voice. And I don't know that many of us think we are, but we are. All right, let's make that shot count. This is one of my favorite quotes about cats, a happy arrangement. Many people prefer cats to other people, and many cats prefer people to other cats. So anyway. So the principles of vaccination that were set out by the AAFP a very long time ago, when some of these first guidelines came out, are to vaccinate the largest number of animals in the population that are at risk. Each individual no more frequently than is absolutely necessary, and with the agents that that animal is likely to encounter. And then that will actually cause disease in that animal once they've encountered it. And then only when the risks outweigh the benefits. I feel like this should be on the practice wall of everybody's practice, because I think this is what owners are hoping for. This is what we're hoping for. And it's something that I feel like if everyone knew, then maybe we'd be more on the same page for vaccinating our feline and canine friends. The types of vaccines we currently have available for cats. We have inactivated, we have attenuated or modified live. I'm going to use those pretty interchangeably. And those can be intranasal or parenteral. And then we have some recombinant vaccines. So modified live or attenuated, usually viruses or bacteria, because it's an actual replication of that agent in a virus or bacteria that's sort of been dulled, if you will. It can be a very potent vaccine, even after a single dose. So multiple parts of the immune system are being challenged and being responsive. And you have the option of using it, not the ones designed for parenteral or into the body, but you have options if modified live for mucosal vaccines. And then they have a long duration of immunity. I've abbreviated that DOI just because it made the slide kind of busy to write out all of that. But the duration of immunity on many of those vaccines can actually be lifelong in some cases. And so they're very robust, very good vaccines. We have inactivated or killed vaccines. Usually, in the ones I'm speaking about here, they're whole agent vaccines. So they're the whole particle, the whole organism. It usually takes a dose and then a booster in 2 to 4 weeks to get full coverage for that disease, full coverage and for that antigen. They're a bit less potent than, as you might imagine, than something that replicates. And you get mostly humoral immunity. So mostly the antibody part of the immune system is stimulated. Not totally, but mostly. And then there is shorter duration of immunity. So, maybe a year, depends on the type of vaccine and the potency of it. And then you might have an adjuvant in it, which is that secret sauce that sort of makes vaccines that aren't typically replicating have a punch, or it might not, depending on the manufacturer and the way they've done it. And then you have subunit vaccines. These are purified or synthesized pieces of that particle, and they also have a shorter duration of immunity. And they are adjuvanted typically, but they can be, less protein necessarily than the whole agent vaccines. Then we have some cool stuff. This is where we get into the real creative things scientifically. Recombinant DNA vaccines. There's one out right now that's new and actually live. And the recombinant portion is the canine parvo vaccine. And because it is a recombinant, so it's something that's not necessarily in nature, it breaks through maternal antibody really, really well. And there's others that are going to be on the market. So that's why I mention it here. We don't have any for feline necessarily right now, but they're potentially going to be coming. Recombinant vectored, that's where the recombinant technology is really important for cats. You're going to have immunogenic proteins cloned into a vector. So often it's a canary pox, so something that's not going to be a problem for cats. It's not going to be something that's going to cause disease in them, but it will replicate on a limited level. So you're going to get something that mimics natural infection. And it's usually non-adjuvanted, and it's going to stimulate multiple parts of the immune system. So you'll get that nice, robust response like you do with a modified live. So that's exciting for cats because we'll talk about what adjuvants may or may not be able to lead to as we go along. And then we have nucleic acid vaccines. We all are familiar with some of those from our COVID-19 outbreak. And those delivery systems those platforms are pretty interesting and less expensive to make than some things and fairly easy to produce. Some of our veterinary companies have gotten into making some, mostly for dogs. But again, I can't see why they're not soon to come for cats. So it is an individualized approach. In small animal practice, it's individualized by the pet. And when you get into shelter or group practice, it's individualized by that particular group or that particular population. And it's a bit of a balancing act. And one of the reasons they're guidelines is because we wanted it to be evidence guided for efficacy. Are these vaccines actually worth it? Are they safe? And do they have what adverse effects can we expect? And then this is not something that's in the guidelines, but something I do want to bring up is cost. If you have the best vaccines in the whole world, but they cost too much money for people to be able to afford and give, then there's really not much point. And the risk benefit assessment really does, you do have to take into account those risk factors. And so you're looking at age and life stage. So are they, young and susceptible? What's the maternal antibody level? What's the activity level of this animal? And what's the reproductive status of this animal? Health status. Is there a concurrent disease going on? Are they heavily parasitized? Are they malnourished? Are they going to be exposed to this thing? Where is the geographic prevalence for whatever disease you're talking about? And what's that animal's lifestyle? What's that cat doing every day? I know that we've had several cats throughout the COVID pandemic that actually ended up on airplanes a lot more than before. So again, its lifestyle has become very, very different in this day and age than when I first started practicing for cats. And how they're housed, with whom they're housed, and whether they're inside, outside, and exposure. And then the history, has this animal ever had an adverse event? If we know the litter mates, what's their response been to vaccination? And has there been previous disease in this animal? Do we know this animal's had, herpes or colici or whatever? And then is there any immunodeficiency, either congenital or acquired? And I would include chronic stress in that category because many of our feline patients do tend to be stressed. And can be because of, housing situations, population situations, that sort of thing. So I would include that in our immunodeficiency discussion. So we have to talk about maternally derived antibody because it's super important, but it's also super harmful to our vaccine status. So maternal antibody initially protects. It's your passive immunization that babies get from their colostrum from their mom. But the problem is this going to interfere with kitten's ability to respond to your vaccine? It inhibits IgG production within the neonate through negative feedback mechanisms. And so you give that vaccine, but that animal may not be able to respond depending on how much passive immunity they have. And the period when the MDA is insufficient to provide that complete immunologic protection, but is still enough to interfere with the active immune response, is known as the susceptible window. And this is sort of a graphic representation of that susceptible window when you're going to get your MDA coming down far enough that you're not going to get any sort of protection, but you're going to get interference going on. And you've got to figure out where to vaccinate in that series to know in that time frame to be able to give some protection to that animal. The problem is that maternal antibody declines at variable times between individuals, and it's impossible to protect without immunologic testing. I can think that most of us, if we said to our small animal clients, we're going to test your animal every 2 to 4 weeks, but until they're 20 weeks of age, they would probably look at us like we're crazy because that's going to be a lot more money and a lot more rigmarole than vaccinating. And you're repeating those doses within that window. Those are technically not boosters. Those are actually repeating the dose within that window because you're trying to catch that space where that animal is able to respond and not be denied by our maternal antibody. And this is mostly I'm talking about something like FERCP. You're talking about a killed vaccine that you might give or an inactivated vaccine that you might give later. That's different, but we're talking mostly about your FERCP in this space right here. Several studies suggest that a third of kittens may fail to respond to the FERCP at 16 weeks of age. So we know that MDA in some of these cats lasts up to 20 weeks. I guess if you're thinking about trying to save costs and not having to do all these boosters, you could potentially isolate this kitten and then give your initial vaccine at 16 weeks. But that would be sort of a crazy situation, but I guess it would be possible. That's a question I get sometimes from veterinarians when they ask the guidelines committee. So the feline populations I am referring to and that we talked about in the guidelines are pet cats, shelter cats, trap, neuter, and release cats, cattery cats, and foster cats. And there's my Hamilton cat about not wasting our shots. And we're going to talk about vaccine schedules. So we're still using the concept that many of the vaccine guidelines have used in the past of core and non-core. Core vaccines for cats, so the vaccines that need to be given to cats because either the disease is so harmful that we think that every cat should be vaccinated, or so possible for these cats to get that we think that every cat should be vaccinated, would be rabies, FERCP or Calici panleukopenia, and herpes. And then FELV for kittens, because kittens are so much more susceptible than older cats based on how that virus works and how the immune system of cats works. So when we were developing the guidelines for AHA and AAFP, we went along with the WSAVA recommendations. The 3-year vaccine that we normally give at a year of age for our cats. So at a year of age, they normally come in and they get their 3-year rabies and their 3-year FERCP, or if you're using recombinant, a 1-year rabies, the recombinant 1 year. We normally do that at a year, but now we're backing up that vaccine to 6 months of age, because that then will allow us to vaccinate 3 to 4 weeks after maternal antibody hopefully declines. And so that protects cats for that second 6 months of their life, and allows us to be able to not have to vaccinate with another vaccine. It does require an additional visit for that first year. So you get that 6-month visit, and then at a year they come back for their rabies and FELV if they're going to be due for that, and they're going to still be at risk. Eventually, as the animal gets older, you could time that with rabies. You could extend your FERCP and reduce your rabies due dates, and so you could time it eventually so they don't have to do this every single time. But at least in that first year of life, we want to protect cats during their second 6 months. And we have the opportunity to make this a good thing. Those of us in small animal practice have really talented technicians, and they are really helpful with this visit. Hopefully we can use this to make this a very happy visit, not something that the cat sees as, another torture event. You might consider half-mil vaccines, which are on the market now, so they're faster. And it gives the owner another chance to practice getting that cat into a carrier, leaving that carrier out, doing all the things that we educate owners in doing. My technicians are really good about getting out all of the things. We have treats, we have the little fishing poles with the mice on the end of it. We have even a mobile that puts fish on the wall in our cat room. We have catnip, we have pheromones, and we can give this vaccine in sort of in response to all the different things we're doing, sort of slide it in there in the visit. And so, it doesn't impact them quite as much as maybe it would if we were doing more vaccines and all of the other things that we tend to do within vaccine visits. So adult pet cats, we're talking about non-core risk vaccines. FELV in adult cats is a risk vaccine. FELV is more difficult for adults to get, and so if they're not at risk, we do not advise vaccinating for it. Chlamydia is a vaccine that we would only give in at-risk situations. Bordetella, again, a vaccine only in at-risk situations. And I include FIV, not because in America or Canada we're going to be dealing with it, but there are other parts of the world where they are still giving this vaccine and using it and finding success with it. So I do bring that up because we're not just isolated in a little vacuum here. So with the leukemia vaccine, you really do, it's a retrovirus. So you have to make the immune system see a retrovirus in cats without adjuvant, hopefully, or strong replication. We had an intradermal vaccine, which put that vaccine right where the dendritic cells were that are the most responsive antigen-presenting cells that the body has. But if any of you remember the vet jet, it was terrifying to cats. It was loud. It was all of those things. You had to get it right up against the skin. And so it was discontinued. But what we've done, being able to do now, is use our canary pox shell vector to stimulate both arms of the immune system, as well as putting genetic code in there that helps not only get that animal reactive to that particular antigen, but also super stimulating the parts of the immune system that we're hoping to with, say, a modified live vaccine. So now we have with FELV vaccination and revaccination, we have an inactivated product. Could be adjuvanted, could be non-adjuvanted, and we have a recombinant canary pox vectored option. So this was a bit of a discussion between the parts of the committee because we have some really good studies with our inactivated products, and we have some good studies with our recombinant vectored products too, but the duration of immunity on those studies is not quite as long. And so basically what we said was you want to vaccinate based on the risk for that particular cat or that particular population, and you want to repeat your vaccine in 2 to 3 years, depending on which vaccine you're using. I know that if I had a cat in a very, very at-risk situation, so say housed in a very enclosed option with other FELV positive cats or with FELV positive cats, I might even consider upping that to yearly vaccination. It's a scary disease. It's not something that I would want a cat to get when I know I can prevent it. We also have to think strongly about what our risk factors really are. So this kitten here, he's a cat, but kitten is a cat that's a barn cat that really doesn't interact maybe once in a great while, every few years with another cat. So his risk is considered fairly low or no risk when it comes down to it. And so again, really have to get into that history about what's going on if you're dealing with an individual situation. And then we have our not generally recommended. We know that FIP, the state of FIP, the actual virus, as well as the vaccine, it doesn't really match up to give good protection. Fortunately, now we have some treatment options for FIP. And then, like I said, FIV is not available in this country anymore, but in other countries it is. It is not very cross-protective between clades, but in some countries they're finding success with it being somewhat protective for their cats. So if you go to our shelter population of cats, FERCP is still considered core, and your parenteral is the one that's most often used. There is an intranasal option, and the intranasal is going to be your faster protection. The only problem is it's not great protection for your panleukopenia. So in terms of what we might use that for, you might actually start with your FERCP, parenterally and give every 2 weeks for kittens until 20 weeks of age, and adults on intake and repeat in 2 weeks. But if you have a very high risk situation, you might actually use, say you have an outbreak of colici or an outbreak of herpes, you might actually use the intranasal and the injectable at the same time. So you would get a faster response to your herpes and colici and a robust response to your panleukopenia. And you can actually, most of the time we say do not vaccinate kittens under 4 weeks of age with your FERCP. But if you have high-risk kittens, they can get the intranasal bivalent, which has herpes and colici. So if you have really young kittens and you have an outbreak situation, it may be something worth thinking about. And then vaccination, we used to think that should be avoided in retrovirus positive cats, but now we know something that we should be giving in those situations as well. Obviously not critically ill animals, but animals that are merely positive, then yes, they should be getting vaccinated. Rabies, you have the options. You have your inactivated vaccines. You have the same vaccines that you have for dogs that we can use in our feline patients. You also have the canary pox vectored 3-year and 1-year vaccines. Those can be used just like in our pet cats, in our shelter cats. And then you have the same options with your FELV. You have inactivated and canary pox vectored. They are, again, both, in terms of the FELV, you may or may not have adjuvant and you're inactivated. Retrovirus testing is very much advised if you're going to be doing vaccination for retrovirus, and that's definitely recommended in group housing. And FELV vaccination is not recommended necessarily if a shelter is trying to save funds in individually housed cats or short-term group housed cats, but it is recommended for long-term groups or sanctuary type situations. Rabies, cats and kittens 12 weeks or older, in compliance with your local and state regulations. You might administer at the time of intake or prior to release, even if the vaccine interval between other vaccines is less than 2 weeks. We still recommend getting that in that animal so that they're not going out without some protection from rabies. And do not hold a cat in a shelter to receive a rabies vaccine. So if your state says you cannot give a rabies vaccine in that shelter unless the veterinarian is there and that veterinarian doesn't come for another 2 weeks and that animal could be adopted out that day, go ahead and adopt it out. But you encourage those folks to get that animal vaccinated within 4 weeks of adoption. This was a lion I actually got to do some dentistry on, and I've been looking for a place to put him in to some pictures. So anyway, you guys get to see the lion I got to help with during dentistry. We put in a section for serology and diagnostics. You might want to be using serology for diagnosis of infection. That's completely true. Identification of previous exposure can be another reason to use it, or assessment of immunity. Those are all good reasons to be using your serology and other diagnostics. The cat in the picture there was in our cat room. There is a little shelf right there so the cats can look out our window into our lobby. We do a lot of vaccinating and a lot of examining on that little shelf there because cats seem to be pretty happy looking out the window and admiring our view. So the committee agreed that it's useful when your serology is useful in making a decision to vaccinate in one situation for a cat, and that's panleukopenia, because the presence of antibodies really does correlate with protection. So that's useful to make a decision to vaccinate. Herpes and Callicity, it really should not be an assessment of immunity. So it's not reliable to decide whether to vaccinate that animal. FELV testing, antigen testing could be used to decide whether or not to vaccinate based on whether or not they're positive, not whether they're due for it, but if they're positive, there's really no point in vaccinating them for leukemia. And then obviously rabies is required and serology is not typically used to determine revaccination. It may be used for shipping and things like that, but not for revaccination. There are some potentially therapeutic benefits of vaccination, some non-specific immunity that can be produced, mostly your herpes and Callicity, and somewhat your Bordetella, for animals with chronic upper respiratory tract infections. Mike Lappin's group in Colorado has been able to use it during several times a year with these animals that have chronic upper respiratory infections, and has been shown to give them some protection and relief from these clinical signs. That's not true for the FELV studies, but it is definitely true for your herpes and Callicity studies, and with Bordetella as well. And thinking about the cost of vaccines and serology, your technology is going to be more expensive than your vaccinating or than your stuff that has lower level technology. Not that they're good or bad vaccines, it's just whether or not you're going to be spending that money. So your recombinant is going to be probably much more expensive than your modified lives or your modified live attenuated and your killed vaccines. Problem is that you might have a situation where you can't use that more expensive vaccine. So trap neuter release program might not have all the money in the world to be able to use for these cats. And we may not be thinking about things like fibrosarcoma for these cats in the long run. Shelter situations, again, trying to get some protection in these cats based on the budget that you're given. And then you may be in an income area where people can't afford to do that, and for you to still make something of a profit so that you can continue to have your business. Serology also costs quite a bit. And so those things may be appropriate in certain situations, but they may not be appropriate in others. And more that we talk about things like spectrum of care, this is something that can become very important in offering our cats protection from infectious disease. So let's talk a bit about post-vaccination events. The prevalence of adverse events is really, really low. 1.25 million doses of various vaccines were administered to 500,000 cats, and 0.52% had reactions. So pretty low. Hypersensitivity reactions, type 1 were the big ones we're talking about, the most dangerous ones immediately that we're talking about. And so that's about 1 to 5 of them per 10,000 vaccines. There are other types of vaccine reactions, the generally sore, not feeling good, that sort of thing for several days, other types that you can think of. And then obviously you have your fibrosarcoma issues. And one of the things we really wanted to do in this particular iteration of the guidelines was to really get into the fibrosarcoma discussion so that everybody has as much information as we could give them. We got an epidemiologist on the group that could really dig into this for us. This started to become a problem back when we started to change the type of vaccines we were giving cats. Rabies became a killed vaccine, and we started seeing the first FELV vaccine was released. At the time, that was typically adjuvanted as well. And then the protocol sort of changed, removing those predominantly live products like rabies to killed adjuvanted products. And so that's when we started to see more of this issue. And we know that the long-term safety data back in these times was also not really there. We then decided that we were going to be changing vaccine sites because it used to be that we were giving most of these vaccines between the shoulder blades in the intrascapular space. There was lots of research out there, but unfortunately, it's not as extensive as we would like. There's more in depth than previously, but still not as in depth as we'd like. So the situation is that in what we've studied, it's relatively rare. 1 in 1,000 to 1 in 10,000 vaccinations suggesting a genetic predisposition. And there's no clear evidence so far that the incidence or proportion of feline biopsies that are sarcoma has changed in the US or Canada since we've changed the use of adjuvants and things like that to be more non-adjuvanted products and that sort of thing. And it depends on the distribution in a population of the vaccines. It depends on different susceptibilities, and hospital databases may not be receiving the same vaccines. And so again, it's really hard to tell with the data that we have what exactly we're getting. For this to actually be well studied, we are going to need people in these big companies to really help us out here, I think. We need to have a primary network of hospitals, big, large one, that we could really look into what vaccine types they have and what incidence of fibrosarcoma they have. And owners could be offered choices between, adjuvanted versus modified live versus recombinant to see what is possible and what really was out there in terms of the incidence. So the task force does recommend using the sites that many of us know, so that, and as distal as possible on the limbs, so that if these fibrosarcoma would have to be removed, an amputation would be possible. and post-vaccinal monitoring is essential. The 3-2-1 rule is what we typically use. Anything that's been there for a long time or more than about 3 weeks, or gets longer than or 3 months, sorry, and becomes larger than about 2 centimeters, and continues to increase in size a month after injection, something that you need to be worried about and monitor closely. We do not recommend vaccinating in the trunk, in the neck, in the hind area where that's above the knee. We also there's been some talk of vaccinating in the abdomen, the lower part of the abdomen, because you've got more skin there. However, it's still, when you're looking at how much surgical margins you need to get, seems to be a bit of a dicey area. So this section, I encourage you to read it, did a deep dive into the research talking about vaccine-induced inflammation and how that's not even defined the same between different studies. A lot of the studies are in rodents, which, as you know, the immune system between rodents and cats is going to be quite different. And it's hard to then associate the incidence in rats with the incidence in cats. And so the task force said, we really can't say that there's currently evidence to justify recommending a single type of vaccine for every population in every situation. It's just not there. In the human world, they would not even do this based on the amount of evidence that we have here. So we really need more evidence, if at all possible, in order to do this. So practitioners are strongly advised to keep current and complete accurate records of the vaccines they're giving, where they're giving them, that sort of thing. And they may need to use medically appropriate discretion in vaccine type and site based upon, again, cost, population, that sort of thing. This particular cat had fibrosarcoma. She's been injected between the shoulder blades for many years, for many times. So it's really not clear which vaccine may or may not have caused that fibrosarcoma. So the other part of the guidelines talks about the role of the veterinary team. Your practice needs to set its own guidelines. And they really are guidelines. They're not protocols, they're guidelines, because protocols implies that you're going to be using the same thing every time in every animal. That may be true if you're in, again, a group housing situation. But if you're in a general practice, you're going to need to have a specific set of guidelines that can be tailored to the practice that you have. And you need to create a culture about it. Vaccines are important. They're not the be-all, end-all of what we do as practitioners, but they are critically important, and they come with some of the same risks that doing surgery comes with. And you need to be the ultimate authority as the veterinarian in that practice and educate the staff and find people that can be good at educating your staff. And this particular kitten here is in this cube. I have several scars from this cat. She's hyperthyroid, and we had to draw her blood quite frequently. And when we got these cubes in our cat-friendly room, she decided that if she was in the cube, you could draw her blood all you wanted to. Outside of the cube, not so much. So we were able to, in the last part of her life, do lots of things, but I still have the scars to prove otherwise. Your credentialed veterinary technician or veterinary assistant may be able to help you in this education of the staff. And even your reception or client service personnel need to be educated in this, because they're going to be the ones, when that person's calling on the phone to figure out what needs to be done for their animal, they're going to be the ones receiving that call. Also, they're going to be the ones seeing that owner run in with that cat that's having an adverse event. And so you need to be able to have all of them be somewhat educated in the culture that you want to have in your practice about vaccines. And clients are also essential parts of your veterinary team there. And so in our guidelines, we have talking points, handouts, responsibilities for clients, all those things, so that you have tools that you can then use to give those clients to help them be a part of that team, to help them be a responsible group, to helping you get your patients vaccinated. This is our cat from the previous slide after she had her sarcoma removed. She had other problems, as you can tell. But after she had her sarcoma removed, she lived another several years and it did not return, thank goodness. But yeah, she was quite the model. And the guidelines are online friendly. So you can have, them on your phone, you can have them in your exam room if you'd like. And there's a lifestyle calculator on there, a fact sheet. There's even a little chart that I included on this slide that you can, a magnet even that you can put on your refrigerator if you want to look at vaccine schedules and that sort of thing and what's recommended. And sort of an easy look, if you will. So one of the other things I'm going to touch on and cover here is how to handle vaccines. This is something that I didn't learn in vet school, and it's something that I watch practitioners struggle with, and it's something that I think could be done better for all of us and make vaccines more potent for both our dogs and cats. You need a vaccine coordinator for your practice, somebody that is looking out for what happens with all the vaccines, not just your supply person, the person that generally does inventory, but somebody that's looking specifically at vaccines, as well as a backup for that person. And the role of the vaccine coordinator oversees all things about receiving, handling, and storage of the vaccines. They're going to order vaccines. They're going to be responsible for helping you to educate your staff, overseeing the proper receipt and storage of vaccine deliveries, organizing vaccines within storage units, setting up temperature monitoring devices, rotating your stock, removing expired vaccines from your refrigerator, responding to out of range temperatures. This didn't used to be a thing back when I first started practicing, but now you can have your thermometer in your refrigerator hooked up your smartphone, so you know if that refrigerator goes up in temperature. And then maintaining all the documentation, such as inventory and temperature logs of your vaccines, and ensuring handling of those vaccines during a disaster or power outage. We're having that winter storm right now in America, and that's something that we can know will cause some power outages probably. Maintain that cold chain. When those vaccines get there, they're cold. They need to stay cold. So that needs to become under the immediate attention of your vaccine coordinator to unpack that shipment. If you can have a purpose-filled or purpose-built unit for your vaccines, that is so much better than a regular household refrigerator. The temperature is going to be maintained more continuously throughout that unit. The dormitory style refrigerators are not great. And if you're going to have to use a regular household refrigerator, don't use your meat and fruit drawers or vegetable drawers. Use your regular compartment that's inside your refrigerator. And ensure that it stays closed and that the seals on that refrigerator are working. Between 2 degrees and 8 degrees Celsius. And make sure that you do not freeze. These vaccines, many of them are not appropriate for freezing. So make sure that your temperature is not too cold or that's uneven to allow freezing. And never monitor by appearance of the vaccines. Always monitor by the temperature they're being kept at. This particular cat is hunting for lettuce, believe it or not. This is Dimitri, and he was very, very much obsessed with finding lettuce in the refrigerator. The CDC advises that continuous monitoring and logging, again, it's easy to do now with your smartphone. So something that you can do, that vaccine coordinator can do. And then the administration, the last step in that cold chain. Prepare your vaccines in a non-contaminated area. Single dose vials if we're talking about small animal vaccines, cat vaccines, are much more appropriate. And then make sure when you're reconstituting that you're using the specified diluent. They're not necessarily interchangeable. So make sure, unless it's specified that they're interchangeable, make sure that you're using the appropriate diluent. And I say just go with no pre-draws. If you are drawing up vaccines for a room and you're giving it within 30 minutes, great. If not, I would say don't use that vaccine. That's just a nice general rule for everyone in the practice. You may want to get more specific in that, but what I find for my crew is that's my limit. Label your vaccine syringes. You can have different kinds of vaccines. Your modified live mucosal vaccines, you never ever want to put parenterally. And so those are things you want to make sure they are labeled very appropriately. Check your expiration dates. Make sure before you give that vaccine, you look at your expiration date and make sure you're giving it through the appropriate route for that vaccine, the route that it is labeled. The CDC has a really nice storage and handling toolkit. It's a little training module that you can have your vaccine coordinator do. You call the shots, vaccine storage and handling. It's a lovely little document and online module that may help you out in training your staff. So as private practitioners, we don't often think of ourselves as part of the group that needs to be concerned about creating herd immunity. But the more proportion of pets that we can get vaccinated, the better. And so there's concern in many countries about the low proportion of pets receiving vaccines, particularly rabies. And that low proportion decreases the herd immunity. And the vaccine frequency, so in vaccinating this small proportion of animals over and over again is not as important as vaccinating more of those animals. So a well-timed core vaccine could be just as important as vaccinating that cat over and over again throughout the years. I just put this little chart in here. I can think of having herds of cats as being maybe hell on earth, but it's something that we need to think about, even with cats per se. And again, we need to be prepared for that next pandemic. We as veterinarians particularly. And we know that many human pathogens have animal reservoirs. Right now, we're looking at cats as if you've got cats around your dairy farm that are starting to act neurologic and dying, you're going to be thinking about H1N1. And so that's something that we can, start to think about. And maybe there'll be new vaccine development that can help our feline friends with these problems, especially with our new platforms that are out there and the company's interest in development. We haven't had new vaccines come out for felines in a very long time, at least in terms of new platforms. So we all have to deal with vaccine hesitancy, and I'm not sure whether COVID made that better or worse, to be honest. Delay in acceptance or refusal of vaccination despite availability of vaccination services is essentially what I'm talking about. Overall, it's one of the top 10 threats to global health. And in 2019, there were studies that looked at pets reported to have a decrease as compared to previously in core vaccines, cats particularly. And so people were asked why. Expense was mostly the thing, but also stress. Putting that cat in the carrier and getting that cat to the veterinarian is as stressful on the owner sometimes as it is on that cat. And so, it's important. Also, we've had a decrease worldwide in the availability of monovalent vaccines. So separating out those vaccines. So you may not want to give an FVRCP with leukemia every single year or every 3 years. You might want to give that leukemia more frequently, i.e. having, options is a very good thing in terms of getting more of the population vaccinated. So in summary, we talked about the vaccine guidelines. I encourage you, not just because I was part of writing them, but to have a look at the Feline Veterinary Medical Association site and have a look. There's vaccine schedules, the risk assessment tools, latest research and information, particularly on fibrosarcoma. It's online friendly and there is a resource center. Vaccine maintenance and administration is something we forget about, think it's just something we can go on autopilot about, but it is something we actually need to be paying attention to in our practices, and for those of us in academia in teaching our students. And we as veterinarians, dog, cat, whoever, whatever species, whatever line of work we're in within the veterinary profession, we need to be looking at, vaccines as our tool to prevent these global pandemics and other things. So we need to be thinking about that in private practice just as much as some of our counterparts in other types of practice. So that's the end of my presentation. I thank you all for having me, and I'm more than happy to answer questions.
So we will move into the question and answer session. Our first question is regarding barn cats, and an individual wants to know if there's anything documented with regard to the range of a barn cat in order to know that they have no interaction with other cats.
There's really, I mean, I think you have to take that situation case by case, because I don't know that there is any data, none that I'm aware of, with barn cats and having them, know what range they're in. The particular barn cat that I was showing in that slide, I happen to know that area because it was the barn I have. And so there were really no other cats in the area. The coyotes pretty much made sure of that. And so that cat really had no other exposure. I can tell you that there are other cats that I would say had more exposure that actually live indoor only, but they live with, in situations where people bring in cats with unknown vaccine status a lot. So they're in a small space with lots of cats that could be infectious. So I think it has to be taken a bit on a case by case basis. In general, outdoor cats are going to be exposed.
All right. Someone commented about your comments with regard to vaccinations in the tail.
Mhm.
Um, do you have any comments on that? It's not something I had ever heard of either.
So there's a documented paper out about vaccinations in the tail. Um, and I would say that if an animal is under anesthesia, it's shown that we do get immunity. They do get a good immune response to that vaccination. And I think if the animal's under anesthesia and you can give the vaccine in the tail, great. I have not met that many cats that really want to sit still and let me vaccinate them in the tail. So I will tell you that it's not something I typically do, but it is something that other practitioners have had really good luck doing. So if if that's something you would like to try, I think it's, something, give it a shot, if you will. But I'm not sure that it's something that I found to be less stressful on the cat necessarily.
Well, and we had one of our attendees comment that they have done vaccinations in the tail for a tripod, a three-legged cat.
There you go.
So,
Yeah, no, I think for some it works great. I think for others, not so much.
okay. A little bit about maternal antibodies. Is there a concern for vaccination of kittens, quote unquote, consuming the maternal antibodies and increasing risk? I'd never heard of that, but a coworker was worried about it in puppies.
I mean, I think you have to, because you don't vaccinate animals from the time they're a week old, they need to have those maternal antibodies. They need to consume them. They need to have placental transference and colostrum, because otherwise they're not going to be protected in that very early time. Yeah, there's risk for vaccines being blocked for sure, but I think, it's more important that they have it and that we figure out ways around it responsibly as we go forward. I think that answers the question. I'm not sure I understand entirely.
Okay. If that didn't answer the question, please type in your clarification,
Absolutely.
clarified question to that
Mhm.
individual that posed that question. Someone's asking about trap, neuter, vaccinate, and release cats,
Mhm.
whether all vaccines can be given at the same time. Um,
Yes, they can.
yeah, okay.
They very much can be given at the same time. And I advise it if you're doing a trap, neuter, release situation, because you want those animals to get it before you no longer get your hands on them. So I would rather have them have an FERCP, rabies, leukemia, if you're able to give it, money wise for that trap, neuter, release. And that way they've at least seen all those things once.
Well, and like you said, you wanted to do it while you can get your hands on them, and you don't want to give them a second opportunity for them to get their hands on you. Some
Um,
of
Someone in
them.
the chat also had a very good point that maternal antibodies are protective for a very broad range of diseases. Absolutely. They're protective for a lot more than just the vaccines the antigens that we vaccinate for. So yes, they're critically important.
Okay. Um, Someone says before or after surgery, they separate FERCP before surgery, then give rabies after. Had you ever heard anything about like that?
I mean, if that's what you've found comfort with in your practice, that's great. I tend to, if I'm going to vaccinate a cat in surgery, around surgery, I tend to vaccinate them as they're waking up so I can tell if they're having a vaccine reaction. But again, if it's been working for you, often cats don't react terribly to FERCP. So if that works for you, I say go for it. We know that surgery is not a detriment to vaccine response. At least not surgery for things like spay and neuter. If you're giving surgery for a disease, that might be a different thing for a sick animal.
Okay. The maternal antibody person that posed that question came back and said if if the maternal antibodies are being used up by vaccinating early, so when they have less maternal
No,
antibody to protect them and aren't protected by the vaccine.
no, they're not. There's no evidence to show that that's the case.
Okay. Towards the end of the presentation, you spoke about refrigerators and vaccine storage. You pointed out a lot of things that I'll self-admit I did wrong back in my day in clinics.
Me
Uh,
too.
yeah, can you elaborate on the difference between a purpose-built fridge and a regular fridge?
So a purpose-built fridge is going to be much more able to keep the temperature throughout that refrigerator consistent. In bigger fridges like or multi-purpose fridges, the air circulates and there are supposed to be zones. So there's supposed to be zones that are more cooler than others, that sort of thing. And then you also have either the freezer at the top bringing cold air down or the bottom bringing cold air up or side to side. And so you have much more options for cold spots, hot spots, things like that. So if it's a consistent, unipurpose refrigerator, then it's going to be the entire thing is going to be kept at a focused temperature, at a consistent temperature.
And is that the rationale for not using the drawers and
Yeah,
yeah.
because those are even very much different temperature than the rest of the refrigerator.
Okay, we've kind of come to the end of our questions. I definitely want to thank Dr. Stone for this presentation to kind of remind us well, it's one of the core areas of the ACVPM, surveillance, prevention, management, and control of diseases. Definitely refreshed my memory and provided some new knowledge on feline vaccines. So I want to thank you for the presentation. I will turn it over to Dr. Stephen Castle if he had any last comments. He is the chair of the ACVPM's Continuing Education Committee.
Thank you, Dr. Toring. I just wanted to add my thank you to Dr. Stone for the great presentation. Lots of applause that I see going up there. So just remind everybody that we try to do this about once a month. So we got some great presentations coming up in the near future to go along with this. I think next month we're going to be talking about the MVAP program presentation from USDA. We have some presentations on or webinars on rabies. As well as a little bit later in the summer, some brucellosis, canine brucellosis. So a lot of infectious diseases coming up. If you have any recommendations, please send that to the CE committee and we'll try to find somebody, or if you have a speaker, even better. And we'll try to get that scheduled for the upcoming next few months. The 1 month that we don't have usually is July. We'll have the AVMA convention. And I'll just go ahead and put a plug in. I know that we'll have a survey coming out pretty soon. And then we're going to have some questions about what you want to see for CE. So if you don't mind answering those questions, we would appreciate it. So other than that, thank you, Dr. Toring, for guiding us through this, and Dr. Stone again for a great presentation.
My pleasure.
All right, great. And as Dr. Castle said, a lot of positive comments in the chat. So the presentation was well received. Keep an eye out for invitation to our February C webinar. We have not set a date yet, but keep an eye out for that invitation. So everybody, thank you very much. Wherever you are in the world, be safe and hope you're staying warm. Have a great evening. Bye-bye.